I will. We are on the next slide now, Neil.
Okay, awesome. Thank you. To understand how we ended up in this situation, we need to go back to 1950. Cortisone wins the Nobel Prize, and almost immediately, labs around the world start testing it on every tissue they can find. Three independent groups in Argentina, Britain, and France published within a year of each other, all showing that cortisone suppressed the fibroblast activity and collagen formation in cell culture. By the mid 1950s, clinicians are already trying systemic ACTH injections in keloid patients. Then in 1963, the first intralesional triamcinolone acetonide injection is given after surgical excision. It's not published until McGuire in 1965 and then Ketchum's landmark paper in plastic and reconstructive surgery in 1966. Here's a critical point I want you all to take from this slide. From the very first injection, the dose was chosen empirically. Nobody ran a dose finding study and nobody established a minimum effective dose. They used what they had and it seemed to help. And that assumption has carried forward unchallenged for 6 decades. Next slide, please. Fast forward through the next 50 years, TA becomes first-line monotherapy through the 1970s and 80s, which recurrence rates already showing around 30% at 1 year and 50% at 5 years. By the 2000, 40 milligrams per milliliter has become the clinical default, often stacked with surgery, laser, or cryotherapy, and still with no systematic dose response data behind it. Then the side effect reports start coming in. Skin atrophy, hypopigmentation, telangiectasia, Cushing syndrome in patients receiving repeated injections. And in 2021, a systemic review and meta-analysis confirms that 20 to 40 milligram concentrations are significantly more likely to cause atrophy and telangiectasia. And Belai and the colleagues show that adverse effect occurs in up to 91.4% of patients in at high doses. So, where does that leave us? It shows that we have a treatment used for over 50 years, causing side effects in nearly every patient at standard doses, and we still do not know what the minimum effect dose is. That is the gap that we are trying to close in our study. Next slide, please. In this slide, it shows like on the left panel, you can see the dose variability in clinical practice. 1 to 80 milligram per milliliter range reported in the literature. 60% of studies use 20 milligram per milliliter or higher. 40 milligram per milliliter, which is Kenalog 40, used as default. And some experts advocate 2 milligram per milliliter based on pharmacological principles, which Dr. Tirgan is among them, and no consensus or minimum effective dose. And then there are some side effects. In the local side effects are skin atrophy and thinning, telangiectasia, hypopigmentation, tissue necrosis, and then there are also some other systemic side effects. Next slide, please. Because there are no animal models for keloids and clinical trials take years, we took an in vitro approach. What we did was that we isolated primary dermal fibroblasts from keloid patients, 3 cell lines, and 1 normal human dermal fibroblast as a control. We then treated them with a 1,000-fold concentration range of TA from 1 micromolar up to 1,000 micromolar. What you see in this graph is cell viability at each dose, and two findings are standing out here. First, there's a clear statistically significant dose-dependent reduction in viability from 1 up to 50 to 100 micromolar of TA. And second, beyond 100 micromolar, viability does not drop further. And the curve gets flattened, and this is a plateau. This is a plateau, and it is consistent across all three patient-derived cell line. So the next question is that, like, what does 50 to 100 micromolar in a culture dish actually correspond to a keloid patient, which I will discuss it later. Next slide, please. This slide shows the same story from a different biological angle. This time, looking at type 1 collagen and alpha SMA, the two main drivers of keloid fibrosis. The immunofluorescent panel on the left shows cells at each TA concentration. Green is type 1 collagen, red is alpha SMA, blue is DAPI nuclear stain. And you can see what happens as you go down the rows. The green and red signal clearly fade from untreated to 1, 10, and 50 micromolar. And then if you look at the 100 micromolar and 1000 micromolar rows, they're essentially very similar, and there's no meaningful further reduction. The bar graph on the right quantifies this across replicates. Both markers drop significantly up to 50 micromolar. The message is the same as the viability data. The therapeutic ceiling is somewhere around 50 to 100 micromolar, and beyond that point, more drug gives you more toxicity, but not more efficacy. Next slide, please. This table is the bridge between the lab and the lab bench and the clinic. We used a method called quantitative in vitro in vivo extrapolation, QIV, to convert our in vitro concentration into clinically meaningful intralesional doses in milligram per cubic centimeter of the tissue. The model scales by tissue thickness and applies pharmacokinetic corrections for TA's depot effect. And we factored in a standard 3 to 4 weeks treatment intervals. You can see the highlighted rows, 50 and 100 micromolar, are therapeutically effective in vitro range translate to 0.3 to 0.55 milligram per cubic centimeter in vivo. Now, you can compare that to the clinical practice. The lowest doses ever reported as effective in the keloid literature are 1 to 2 milligram per cubic centimeter, and our predicted minimum effective dose is 3 to 7 times lower than that. The right columns tell you the injection volume, just 30 to 55 microliter per cubic centimeter using the standard 10 milligram per milliliter solution. And this model, the QIV model, assumes uniform tissue distribution. It does not account for drug clearance or ECM binding. And these are computational estimates that require clinical validation, but the alignment between our extrapolated doses and the clinical evidence for low dose efficacy gives us real confidence in this direction. Next slide, please. Now, let me bring out our 4 key findings together. TA works. It suppresses type 1 collagen and alpha SMA in keloid fibroblasts in a clear dose-dependent manner. There's a hard ceiling around 100 micromolar in vitro and no additional suppression of cell viability, collagen, or alpha SMS is achieved above that threshold. So the plateau is real. High doses cause harm in up to 91.4% of the patients with no evidence of additional therapeutic benefit over lower doses. And QIV extrapolation places the minimum effect intralesional dose at 0.3 to 0.5 5 milligram per cubic centimeter. So we need prospective clinical trials testing TA in the range of 0.25 to 1 milligram per cubic centimeter. And if those doses prove effective, we can eliminate most of the side effects burden and improve patients' compliance and reduce the cost. So the biology is there, the computational support is there. What the field needs now is the clinical trial to validate it. Next slide, please. So first, I would love to thank my advisor, Dr. Akash Kunjan, for always patiently guiding me through all of this, my projects, and for letting me to be part of this project. And second, I would love to express my sincere gratitude for Dr. Michael Tirgan, not only for his scientific mentorship and collaboration on this work, but for personally arranging for me to present online at this time and just for bear with me. And I also want to thank all the technical people behind the scene for made this happen. And also, I want to thank the Biomedical Science Department at Florida State University. And also, I want to thank the patient audiences. And I'm here to take the questions.
For the interest of time, please, from this presentation on, we only allow 2 questions.
Well, thank you. Well done. Very interesting. But you were talking about testing a solution. Did you test a solution or a suspension? Because in a solution, all the drug is directly biologically available, but what we are injecting is actually a suspension. So there the triamcinolone is crystallized, and the crystals are largely not biologically available at the moment of where they are injected, which means that's also why the half-life is so very long. So that makes an important difference.
Yeah.
Whether it's the suspension or the solution.
Thanks for the question. Since it is on the 2D models, on the cells, we use the solution, and it would be the same as the suspension in the tissue, I believe. So because in the tissue, it will be released like the release form would be different, but in the 2D cell culture, it's the solution. But in the QIV assay that we did, we considered the depot effect of the triamcinolone acetonide.